Good morning and welcome everybody. Interesting times, I think, as we've described for everybody at the moment. What I wanted to do today was talk to you briefly about Babylon and what we're doing, the markets we're working in, how we're doing it, but obviously in relation to sort of the participants on this call in terms of what it is, the data we're looking at, why we're recording it, how we're using it. And then finally finishing off with really just a few principles in terms of that we have to apply as a technology healthcare company. And finally, just a few things in terms of learnings to share from you. Right from the get-go, I am not a doctor, I'm not a data scientist. We actually have people at Babylon who are both medical doctors who are working on the AI brain that we have. They're writing code. And then one day a week, they're actually working in places like Frimley Park or hospitals up and down London and across the Midlands. So a wide variety. What we're trying to do as an organisation is the mission why probably about 3/4 of the people who are there, we've got about just under 2,000 people here at the moment, and that is to put accessible and affordable health service in the hands of every person on the planet. So we're currently providing healthcare for around about 6 million people. That is going up dramatically at the moment in terms of our relationships with the National Health Service, and also over in Rwanda, where we now have 2.5 million patients we're handling on behalf of the Rwandan government. And of course, as soon as I finish this call, straight back onto the States, where we will be talking to them about what we can do to help them with COVID. Affordable, accessible healthcare is about changing the way that we do things. And why do we change the way we do things? The reality is that it's a market which is growing so quickly in terms of demand. Everybody nowadays wants instantaneous access to services, whether that's ordering your pizza, clothing, holidays, all of which are probably things of the past, at least for about 4 or 5 weeks anyway. And to be able to sort of do that within the bounds of the finances today. So we've got an aging population, we've got increasing chronic diseases which we have to manage, limited numbers of doctors, limited number in terms of medical resources, even though obviously on our basis Boris Johnson has released a huge amount of money to help at the moment. But under normal circumstances, this is what you'll be looking at. The healthcare market is just enormous. I mean, I prior to being with Babylon, I was in the banking sector and then the software sector. None of the numbers come anywhere near this. So if you're looking at terms of just primary care, so that's your local GP and the services they provide, that's really only the tip of the iceberg in terms of where the spend is. If you look at the chronic condition management and long-term disease, you see that it's actually 3 times what we're spending on doctors and GPs and nurses locally. And where's that coming? Because people are changing their habits, they're changing their diets, and unfortunately, it's not actually working in the right way. So what we're trying to do is to change the balance. And at Babylon, what we're looking to do is to be able to find how can we actually treat more people at a time when there's more diseases becoming aware. Obviously, COVID is part of that, but also there's higher expectations. Some parts of the world, seeing a doctor within a week or even receiving treatment is something that they cannot even imagine. We in the UK kind of sit in the middle. If you go to the Netherlands, for instance, they would be crying blue murder if they couldn't see a doctor within 2 days. In the UK, we talk about 2 weeks. There are a lot of challenges that we actually have to adapt. What we're trying to do is therefore to use technology to be able to leverage the resources we've got already so that we can actually see sort of more patients and handle it more efficiently. If you actually look at some of the changes that happened, it used to take about 20 years to create a vaccine. It's now down to less than 1, we hope. If you're bringing a new drug to market, it's going to cost about $2.3 billion just to bring that drug to market. So, massive changes. And if you look even today in terms of just our interactions with the public, we were, because of COVID, looking at sort of escalating interactions going up to about 100,000 interactions an hour with the public. That's going up to closer to 1 million. That's what the sort of things that we're having to manage at the moment. So the way that we're doing that is through using AI to start with. And at the center there, you will see a pink circle. And typically on the bottom, we would start off and we'd identify a symptom in terms of that be an interaction between a user and the system through a chatbot. We would then use AI in the background to start determining what potential conditions they could be. We would be providing them with some advice about what treatments were available for that, what their next steps would be, and then moving them to rehab and managing them there. Taking that further though, now longer term conditions like diabetes and things such as that, we have to sort of look at what the patient's conditions are, make those assessments, provide plans for them, build them through a coaching system, and also at the same time taking in results from lab tests, wearables, that type of thing. So that's all a sort of technology way of trying to leverage the existing resources we have with doctors to provide the outer rings, which is basically the virtual services and physical services that somebody provides. And the way that's done, it starts off on the left-hand side there with the symptom checker that we have, and that we'll have a look at a bit more detail later in terms of sort of background to that. But the idea here is that actually what you're doing is you're trying to ask questions which are related to the symptoms, but you're also trying to ask it in relation to things that you know about the patient, so their age, their sex, where they live, that type of thing. And then we would then take that through to, if we can't actually solve it for them through the symptom checker, then we would go into what is more traditionally known as telemedicine and do virtual consultations with them. I mean, to give you an idea there, the times of virtual consultations now have gone through the roof, purely and simply because normally we'd be expecting to see a doctor in about 20 minutes. Our virtual consultations, now you are looking at much longer periods, purely and simply because the traffic that's out there. But what we're trying to do is to gather data from you as an individual and trying to get you to change your lifestyle. And if we can get you to change your lifestyle, then your preponderance to become susceptible to particular disease will therefore drop off. So we will do what we call a health check, which is taking details from you by interactions to understand what your lifestyle is like in terms of activity, what your nutrition is, what medication is on, types of things like that. And then we build this avatar of you as an individual. And some people would say this is great, some people would call it a gimmick, but it allows you to drill into vital organs within your body and to be able to start working out what types of diseases you can become susceptible to, but more importantly, what changes can you make to your lifestyle in order to be able to alleviate any challenges that may come. And if you see on the left-hand side there, you'll see some green, orange and red bars. Basically, obviously, the green means you're fine. The orange means that you're within one standard deviation of the population for your age and sex to have a problem in that particular area. And what it will then do is then take you and start giving you advice about how to change your lifestyle. Personally, I've done this quite a few times. I'm not sure it's always accurate because it keeps telling me I've got to eat much less red meat and cut down on red wine. I don't think I actually do too badly on that, but obviously sort of being an individual, you always skew the results and try and start thinking, well, it doesn't apply to me. This is all based on data in terms of the populations of real world evidence that we collect. And on the right-hand side with Monitor, we're bringing in data from areas such as your activity, which we'll take from wearables. It could be blood pressure from wearables. We're even talking with organizations now about sort of smart homes, particularly for individuals with dementia and that type of area. And a good use of data, but then an ethically questionable one, has occurred in China with relation to COVID. And what the Chinese government did with telco was they identified individuals by their telephone location to COVID hotspots. And then they contacted those individuals to say, you have been in a particular area where there's hotspot, and force them into quarantine. So, that's government stepping into data and checking where you are. It really is quite big brother, but under the circumstances, some people may say that's justified, but I don't think we're here to debate that now. The monitoring section is where we would look at your diet, and if necessary, we would look at what you're proposing to eat, and they can make proposals for alternatives around nutrition. But all of this has to be localized, and we'll talk about that later. But let's get to the analytics and what we're talking about today. And we have built probably what is the largest medical brain in the world today over the last 5 years. And this is just, quite frankly, it's been by throwing information into the system, by bringing together data scientists to format that. But also, very importantly, it has to be the doctors who are actually driving all this. So knowledge is very much the published data, the journals, what doctors get taught at university and colleges. Perception is very much around MLP. So we have to be able to look at, even English in the United States versus English in the UK is different, not just from the spelling, but what it actually means in terms of what's being said. Likewise, with the learning, we do that through machine learning and building that. What we're trying to do, though, is actually start building a process to say, what disease do you potentially have and what are the treatments? And that's the reasoning and decision-making components of the brain. And that's, we'll talk about PGM in a minute. And then finally, prediction is the output you would have seen from the health check, where we're trying to start working out, based upon your current circumstances in terms of health, activity, nutrition, etc., what are issues you may occur in the future. Those are the components: knowledge, perception, reasoning. All of this is a continuous basis. One of the key things, though, about that we come up with this is the PGM. And this is where you will go into the system, and dependent on, again, your age and sex and the symptoms you put in, it will start asking you a series of questions. And based upon the answers to those questions, it will give a probability of what that may be and add in further symptoms to this. What we can't do, which is different probably to a lot of AI, is we cannot just have a black box. Everything we have to have in here has to be traceable, so that when a clinician receives the potential diagnosis from this, they can actually go back and see why the system actually came up with that diagnosis. It defines the next question and goes through that process. And this is where our doctors have to build into the system several things. The first part is obviously the epidemiology. So we are going around the world building these epi models, and only at those points can we actually release them. So we have epi models for the UK, for the USA, and we have them for a number of the Asian countries and in Africa. What you don't have, though, is the ability to say, just because you're based in the UK means that it's the same epi model that happens in, let's say, Italy or in Germany. Those are different models. So we have to be able to go build the epi models, we have to build the localization. Then there's the validation from clinical and testing. And this is really where the detail comes in. So whilst we can build the first part quite quickly, the actual validation and everything that goes through that is extremely lengthy. And why we do that? Because what the output of this is a medical device which is certified. So in the European Union, we have Class 1 medical device, which is shortly going to be a Class 2B, I believe, later in the year. But it's a process where there's a governing body that defines how this works. And then obviously then we have to put in the UI and work around testing and how that works with the individual. If you look at the standards that we are, this is just within the UK. You then have to apply on top of that standards from the United States, individual countries. So everybody has a say in what's happening in their area. Why? Because whatever we produce has to be, first of all, do no harm, it has to be safe and it has to be secure, because we're talking about, literally in some cases, life or death. So the kinds of data and information that we as a business, and I want to sort of widen this out a bit, I think sort of David and Vicky were talking before, they were saying, it's across the business, and it absolutely is. There's a danger sometimes that when you're looking at analytics, you just look at your outputs in terms of whatever your customer or services you're offering. But actually analytics cover much larger parts of that in terms of, how you actually physically operate your business. So on the right-hand side there, I've given some examples of the types of decisions that we have to look after and where we're looking for data to try and improve those. Because it's those tweaks in terms of the optimization of the processes which are going to allow us to make that leverage of the healthcare professionals and facilities we have today. For instance, do we go to 7 by 24-hour operation? Certainly, we as Babylon for primary care, that's what we're offering. But you will see a lot of the hospitals and the providers starting to look at much greater use of their facilities, but they need information on what that will be. And therefore, what we're trying to do is make sure that for instance, the patients which go through to have, let's say, an MRI scan are actually patients that need it, not because it's simply a tick list component and just send somebody off. So what we're trying to do, again, is to maximize those resources. And that could be everything from the patients that go, but also the scheduling of that. But then on the operational side, we are a business. So we need to understand what it costs us to recruit patients. In the UK, as a primary care provider, we get exactly the same contribution from the local commissioning authorities for each patient as any other doctor. So therefore, when we're going out looking for patients to build up practices, we have to manage that. What's the best use? Employee recruitment. We have a huge demand for resources. I think we were just talking about before, finding data scientists. Where are they? What do we need to Why did they come to us? One of the interesting things that I have seen from Babylon, which probably sort of quite new to me, is staff morale. A huge amount of effort goes into looking at how the staff are performing, what their issues are, and to be able to bring that. And then on the engineering side, we've got very simple things like, how quickly can we spin up machines? How can we very quickly take, for instance, a COVID-19 response and take it to the United States and issue it there in one of the payers that may come out there. Some of the things that come out of this, and to just give you sort of an example, we looked at the patient flows from using the interface and going on to their next part of the journey. So these are people who probably would have had to go and see a general practitioner before. And what they're finding is that actually in only 24% of the cases do they actually need to see a GP. There are other things that we can actually do for them in terms of self-care, self-medication, or just information. They just needed to be reassured about what they've got. But also, there are people who actually don't need to be seeing the GP, actually need to go straight to hospital because whatever they have is actually that important. So how we get through the process of people doing effectively the questionnaire is very important. So one of the things that we look at in terms of the completion rate, we look at the completion rates, and then we look at the UI, and then we look at the focus groups. And what we're trying to do is ensure that we get as many people to complete a session as possible so that we get the best possible advice out of it. Because if they don't do the completion, they will either not see a GP, or they may actually sort of go and see a GP when they don't need to. So again, it removes part of the optimization. Simple things like how our customers interact. Customers, patients, users, depends on what word you want to use. We need them to be able to feel that they are at the center of this. This is not a system which is controlling them, that they are controlling it themselves. Another piece of information that we want to be able to do is to justify why we're doing things. And this was an interesting piece of research we did in terms of patients in London who became Babylon app users. And what we found was that these were typically people who would actually be going to A&E 20% more than others would have expected. Now, why would they do that? They do that because maybe they can only see somebody out of hours, Saturdays and Sundays or after 6 o'clock, and there is no GP service for them. It could be that they just need reassurance. Once they've taken the app, then they start going less than the expected cohort to the local hospital. Now, why is that important? It's important because we need to be able to communicate back to the care commissioning authorities about where the money should be spent in terms of the distribution between primary and secondary care. And secondly, we need to make sure that people see the value in terms of continuing to use this. Another example is in terms of the health check, in terms of the engagement, and that's where we're looking at how we engage with patients going forward. We're looking there in terms of how often they actually use the system and what difference does it make. What difference does it make means that if they see value in it, they're going to tell others. If they're going to tell others, then it will mean that actually we can make a difference in a healthcare system. Actually, sort of in terms of the patient interaction, we're really looking to try and look at how we sort of treat our patients. Do they feel valued? Is this something that they are going to use as a trusted advisor? If they use it just as a simple system and they don't trust it, then it will stay on their phone and get left behind. So by monitoring these types of results, we can then go back and change operationally and train our clinicians in different ways in order to be able to provide the service that we're looking to. Our employees, a very important part for us is actually the doctors and nurses. I think in the UK, we have one of the highest satisfaction rates of any country with our health service, but regrettably our clinicians actually have one of the lowest satisfaction ratings with the system. So we're trying to look at it so that how can we actually offer a different ways of working for our individual doctors. And certainly, we're all talking about home working now. A large part of going to telemedicine and virtual consultations as a first step in digital health means that we're actually able to give a large number of individuals the opportunity to work from home or other environments closer to where they actually live, therefore increasing their satisfaction that way. And then the final, let's say, case study in terms of where we're trying to make a change is where we're linking both the technology and also the individual clinicians. And again, what we're trying to do is manage what is the benefit that we're actually bringing to the system. So in this particular case, this is a service that we did 6 months ago out in India, where there is a challenge in terms of open heart surgery. And we put in a system whereby we actually use clinicians and technology to monitor the way that a patient was treated, to monitor how we could interact. So enabling technology to help them to comply with taking the medication, using technology to do things such as wound management, using technology to be able to look at things such as the information back from the wearables. What we're finding is that we're getting patients who are watching what they're doing in terms of medication. Their infection rate is lower because A, they're on the medication, but B, we are able to intervene much more quickly with things like wound management from cameras and things like that. In terms of the hospitals, and many of these are sort of hospitals where they are looking for patients competing against others, their net promoter score was actually increased. So as an organization, and what we're doing in terms of building the brain and the tenets there is, first of all, we cannot do any harm. I mean, that's a basic thing for any doctor. So safe and secure. We have a big issue with compliance and consent. So I think one of the questions earlier was about that. We looked at that. I mean, for instance, there are 7 levels of consent depending on how far down the system you go. Where we can use it with real world data, then we are getting to much better decisions than standalone solutions. The big thing at the bottom there is this patient data is not for sale. There's a lot of drug companies would love to get their hands on patients and patients' data. We as a healthcare company cannot afford to be involved in that in any way, shape or form. So in terms of asking around the business in terms of particularly our insights team, what did they come up with? Their challenge is the more you produce, the more people then want. And what you want is invariably not things where you're actually sort of collecting the data there in the first place. So you've actually got to build in the data collection points into your original design and not as an afterthought, because it really is difficult to shoehorn that in. Sometimes there are challenges where people make changes to systems, how they operate, and then your analytics get distorted. And so unless the data scientists and the insights team are involved in those changes, I mean, we're not saying don't do them, but they need to be involved so they can actually understand why there would be sudden changes in the outputs that they get. I talked about real world evidence. Collecting the data doesn't always give you the full picture. You've kind of got to, still use common sense as part of this. We're not automating the hell out of absolutely everything. There are still places for people in this, and that's where sort of the common sense comes into it. The big thing is that the data is there as an aid to a decision. It's not something that they're for, to make decisions, leaders to actually give up. At the end of the day, the leaders have to make the decisions. We can only help them with that data that we provide. So that was very quick, but hopefully that gives you a little understanding of A, sort of who Babylon is, and B, how we're using some of that data within our operations today.